I'm Dr. Emily Silverman, and welcome to Talking Dementia with Remo Health. Join us as we explore the latest advances, insights, and strategies that help empower those living with dementia and the families that support them. Each episode, we sit down with leading experts, from physicians and researchers to policymakers and clinicians, to provide you with the resources needed to navigate this complex disease. I'm Dr. Emily Silverman, and you're listening to Remo. Today, we're speaking with Dr. Bruce Miller. Bruce is a professor of neurology at UCSF and a behavioral neurologist specializing in neurodegenerative disease. He is the director of the UCSF Memory and Aging Center, where he leads interdisciplinary clinical care and research focused on Alzheimer's disease, frontotemporal dementia, and related disorders. He's also the founding director of the Global Brain Health Institute. Bruce, thank you so much for coming on Remo.
Great to be with you, Emily.
So, Bruce, you are a world expert in dementia. So I wonder if for our audience, maybe we could just start really simple and talk about what dementia is. How do you define dementia for patients and for the general public?
Yeah, so we define this as a progressive decline in cognitive function, also associated with functional decline. It's a broad term. It doesn't capture the cause. And there are earlier stages of dementia where function remains intact. And in those people with progressive cognitive or behavioral decline where function is intact, we call this mild cognitive impairment.
And how would you describe the difference between dementia and normal brain aging?
To be classified as normal, we really do require that day-to-day function is relatively intact and that our capacity to interact with others, perform activities of daily living is normal.
And at the Memory and Aging Center, what are some of the most common types of dementia you see? And what are some of the more rarer types? And how do you think about common dementia versus rare dementia?
I think Alzheimer's disease is certainly the most common cause of mild cognitive impairment and dementia. It probably accounts for about 60% of the patients we see. More and more, we're learning that Alzheimer's disease doesn't always happen by itself. And so the co-pathology, other causes for dementia often intermingle with Alzheimer's disease. So, for example, the proteins that cause Parkinson's disease, for reasons that we don't really well understand, often aggregate in Alzheimer's disease as well. So we often see people with a mixed problem with Alzheimer's, Parkinson's, and sometimes other rarer proteins that are part of the clinical picture. The other big categories of dementia are vascular. This is, in many cases, preventable. So it's very sad and disappointing when we see somebody who has had multiple strokes leading to progressive cognitive decline. Often that means hypertension, problems with heart rhythm, cholesterol, blood sugar have not been well managed. Third disease I'm very interested in is frontotemporal dementia, which is a disorder of the frontal and anterior temporal lobes. And with frontotemporal dementia, the manifestation is usually behavior, and in some cases, these disorders begin with progressive language disorder. We call this progressive aphasia. And then finally, there's the group of dementias associated with Parkinson's disease. And while many people with Parkinson's disease are cognitively normal, other patients with Parkinson's pathology also develop cognitive impairment. In fact, very common with Parkinson's.
So we talk a lot about diagnosis at Remo and about the importance of early diagnosis. So how can we teach families and the culture and society, but also how can we teach primary care doctors and people who aren't experts, who aren't neurologists, how to pick up on the early warning signs of dementia? So I'm wondering, what do you tell your family and friends about what to look out for?
I say change. So I think in general, our cognition, our motor function, our personality remains stable because the brain is responsible for those aspects of us. And when the brain changes, it can lead to decline in the cognitive or motor or behavioral functions. So in general, I worry about change. And if people notice a change, whatever type it is it memory? Is it movement? Is it the way my loved one behaves? I think that warrants a careful look. One of the important things about dementia is the patient themselves is often, not always, but often unaware of these symptoms. So I think sometimes people come to us when the patient is worried. And of course, every primary care doctor, when a patient comes in with complaints about memory, must take this seriously. Sometimes they don't. Sometimes they're not aware, and sometimes even the relatives are relatively unaware or unconcerned. So I think that's why in primary care, it is now paid to have a relatively brief but cognitive screen for people. So when I go to see my primary care doctor, they give me a screening test. I go through it with flying colors. It's pretty easy. But I think at the minimum, once we reach the age of 65, we need to have this sort of cognitive screening routinely as part of primary care. But whatever age, if someone is complaining about a change or a decline, whether it's the patient, the loved one, the children, friends, that's a source of huge concern.
Some of the most common early signs or symptoms that we think about in pop culture related to dementia are memory loss, difficulty with executive function, difficulty organizing your life, making appointments, keeping track of dates, things like that. Sometimes wandering, sometimes it's making a big financial mistake, missing bills, things like that. We talk a lot about those symptoms on this show. But one thing that's been really interesting about your work is you've taken a deep dive into some of the more stranger manifestations of these diseases. There's two examples that come to mind. Well, one of them is I know you've been very interested in creativity in the brain and ways in which symptoms of dementia might manifest as creative abilities or just things like that. So I wanted to ask you about that. I also wanted to ask you about another symptom that I encountered in my family. Somebody in my family has, I think it's Alzheimer's type dementia, and has this really unusual and bizarre symptom where anything that's happening, he's talking to someone, he's going to a place, he says, "Oh, I remember when this happened last time," or "It was just like this last time." And I looked it up, and we all know about the concept of déjà vu, which probably most of us have experienced at some point in our life, like a brief, fleeting feeling of, "Oh, I've been here before," or "This has happened before." But with this person, it's chronic, it's continuous. And I looked it up and I saw that there was a name for it, which is called déjà vécu, which is basically like chronic déjà vu. And so I was wondering if you could speak to, some of these more bizarre symptoms like the déjà vécu or like, a creative burst of activity being a prodrome of dementia onset. Walk us through some of the more, I guess, strange or interesting symptoms that you've seen.
Yeah, I think one of the fundamental truths that we've learned about all these diseases is that they begin in a very small region in the brain in what we call a circuit. And so as the circuit loses function, sometimes other circuits become upregulated, they become more active. In the case of a number of patients with frontotemporal dementia, particularly when it affects language, we can see, and I think we've shown this with imaging, increased activity in the back of the brain. So the back of the brain where we perceive the world, think about shapes, colors, objects, this part of the brain becomes hot. It becomes more intensively active. And I think sometimes that leads to a real interest in the visual world that was not present before. And in some people, it even leads them to creative activities in the arts, whether it's sculpture or painting or developing a beautiful garden. But this outburst of visual creativity is the first manifestation of the disease sometimes before we actually see a change in language. And I think we see variations of this with all of the degenerative diseases. In some patients with Alzheimer's disease in the early stages, the front part of the brain as the back part becomes less active. The front part takes over. We become more sensitive to the emotions of other people. We tune in more to the way other people are treating us. We become more sensitive, sometimes too sensitive, sometimes anxious. And that's actually the first manifestation of the illness, is that this circuit that is normally dampened down a little bit is increased in activity. This phenomena is, I think, part and parcel, part of what we see in all the degenerative diseases. I think it's hopeful. It's hopeful in the sense that it gives us a possibility of intervening before someone is really sick. And it also really does capture the continuing humanity of the people with these disorders. It's not like the brain shuts down diffusely. There's only tiny parts of the brain that stop working. So I'm very excited about that space. And when I see somebody, I always think about their strengths. Are there things that we should work with? Are there new things that are more active? The constant déjà vu is very, very unusual. I've only seen it in one person, and that person was referred to me by Emily Silverman. The part of the brain that we use to decide whether something is familiar is hippocampus and the connections of the hippocampus. And we know that the part of the brain, the hippocampus, is attacked in many of these degenerative diseases. Alzheimer's disease, sometimes a protein called TDP43 is attacking the hippocampus. So sometimes we actually get seizures associated with Alzheimer's disease in the early phases. And in someone with déjà vu, I would always first look to see whether there's epileptiform discharges. But in others, I think it may be more subtle. And, I think I know the region where it's hippocampus. It's a warning about a very vulnerable region in elders. Treatment, I think, is not so clear either. I might try an anti-epileptic drug if this continues for a long time. I might try one of the early treatments for Alzheimer's disease, but my experience with this is relatively small.
I think it's such an interesting concept that in neurodegenerative diseases, you have the brain, and there's specific parts of the brain that begin to shrink away, that begin to degenerate, but that other parts of the brain compensate. I guess it's not all that different from heart disease. When you have blockages in your arteries and the blood can't get through, often the body will generate other blood vessels for the blood to go around. Sometimes we call this collaterals. I've seen people who have significant blockages, but their heart function is okay because the body has made these collaterals. It's made these other blood vessels that sort of naturally, it's almost like magic. It's like bypasses the blockage. And so in the brain, it's almost like there's this life force that wants to go somewhere. It wants to exist. It wants to live, and it just has to find a different, I guess, location. I don't know if you've ever thought of the deeper, more, I guess, philosophical or spiritual aspects of that.
Well, it's a battle. I think you're absolutely right. And I'd never heard the analogy about collaterals in the heart before, but I really like it. With dementia, we think about vulnerable regions, and each disease has its own vulnerable region. And why one person is vulnerable in the Alzheimer's circuit versus another who is vulnerable to the Parkinson's circuitry is a little bit of a mystery. But it's a mystery, I think, that we will eventually solve. And I think understanding that brings a possibility of prevention, rehabilitation, getting that circuit that is vulnerable hardier, tougher, less vulnerable to injury. It's been a really exciting decade, at least in high and middle income countries. We now know that at every age, people who come from wealthy country have less amyloid, less of the Alzheimer protein in the brain than people who lived 20 years ago. So we are in a health revolution around prevention. This is a really important story that sometimes we miss. And the story is World Health and Lancet Commission have talked about 14 risk factors for dementia that we need to be thinking about. And not just when we're 80, when we're a child, when we're a teenager. And really, the battle against dementia is lifelong. We touched on the arts. We know that kids who learn how to play the violin have more resilient motor systems in the brain. They're actually bigger. We can visually see this. I think whatever we do during the course of our lifetime, active is good, exercise is good, doing cognitively challenging things. This is part of the battle, and it happens before there are any leaks in the system. This is really important for Remo health listeners to understand that your lifestyle is important. If you are isolated and lonely, you are about twice as likely to develop dementia as another person in your age group. So these are things that families and doctors and healthcare workers have to think about with their loved ones. But also, we all think about it. We all think about protecting our health. I'm a relatively healthy elder, but I wonder if I would be a healthy elder if I didn't exercise like I have for 40 years. If I had smoked, I think my cognitive profile might be very different. So I think these are the health reminders that I think are probably the most important thing that we doctors do for people.
I was wondering if you could speak about the excitement around new treatment. I know that there are some new medications that have come on the market that have shown a little bit of benefit, nothing that's a
Mhm.
blockbuster. um, but I know I've heard you speak about dementia before, and I've heard you speak with a ton of hope and optimism and just courage. And the scientific community is, I think, once I heard you say within a few decades, we're going to figure out how to stop it or maybe even how to reverse it, if not prevent it. And so I was just wondering if you could bring us a little bit into that optimistic view. How do you see the state of the science right now and its trajectory and treatment possibilities over the next period of time?
I've seen in my lifetime waves of approaches that have borne some fruit. So the first big interest in Alzheimer's disease was, can we boost the chemical acetylcholine in the brain, which becomes deficient? And it took a few years, but by 1997, we had a series of medicines. They all work about the same. They're called cholinesterase inhibitors that, like you say, are not blockbusters, but the average person who takes one of these has very little decline in the course of a year. So they should be used. They should be used regularly in people with Alzheimer's disease and also the Parkinsonian dementias. The next wave focused on amyloid, and this protein was sequenced in 1984. So think of what a long, long pathway that has been. But in the last several years, many of the compounds designed to get rid of amyloid in the brain failed. Some of us were starting to lose hope. But then two compounds, lecanemab and donanemab, around the same time, showed that the average person who were given one of these antibodies, if they were early in the course of Alzheimer's disease, not only cleared out this amyloid protein from the brain, but also statistically showed less decline than people who were given placebo. Again, I think you phrased it just right. It's not a blockbuster. My figure is about 50% of people who are given this antibody showed no decline over the course of the 18 months, whereas about 50% of people given placebo showed no decline. Only works in very early Alzheimer's disease. It's being studied in people who are asymptomatic. So we know people go through a long stage where the amyloid is in the brain, but we're not yet symptomatic. Those trials should read out in the next year, and it may give us even more optimism about this approach. So everything we've seen from the anti-amyloid studies suggests that it only works in fairly mild Alzheimer's disease. So it begs the point then, what if we got people before they actually had symptoms? What if we got them when the amyloid was starting to accumulate? And I don't know what will happen with these trials. If they're negative, I think that will be sort of the limits of amyloid lowering. It has a mild effect in slowing progression in people with mild Alzheimer's, but it might do quite a bit more than that. Then the next series of studies are focusing on the tau protein. And I'm a Taoist. I really believe tau is a center of the symptoms we have with Alzheimer's disease. So I think tau lowering shows great promise for the treatment of Alzheimer's disease. And just like in the early days of cancer, maybe we'll need amyloid lowering and a tau lowering drug to help people with Alzheimer's. The imagination of people in research is really high. Jennifer Doudna, the inventor of CRISPR at UCSF, is working on CRISPR to lower tau in the brain or cut it out altogether. Claire Cleland at UCSF also working strongly in this space, Fyodor Umov. So UCSF is a very special place, I think, for dementia, and I think the new treatments are really underway. But other approaches are necessary. We're thinking a lot about how important inflammation is in causing Alzheimer's. So we're really at the very beginnings of, I think, what will be very powerful therapies.
And I know that at the Memory and Aging Center, pharmacologic treatment is really important, but there's also non-pharmacologic treatment. There's a lot else that can be done to help patients and families, and was wondering how you think about that at the MAC.
I think that the days are over when we can just say you have Alzheimer's disease, go on your way. This is a illness that not only affects the patient, it affects the caregiver, the family. My friend Emma Willis, Emma Hemming Willis, who is a partner of Bruce Willis, talked about when Bruce came to see a doctor, he was diagnosed with frontotemporal dementia. The doctor gave him a pamphlet and said, you have to know about frontotemporal dementia, and said goodbye. And Emma said in her book, The Unforgettable Journey, what I really needed was a roadmap. I really needed to know what I would face in the coming year and what I would face throughout the course of this illness. So I'm very excited about that idea. And I think with Emma, we are working to develop what we call a roadmap. So every patient that we see, once this is developed, will have information about all of the legal challenges that they might face, all of the physical challenges. What about cognitive rehabilitation? What are the medications that one should be taking? What are the ones they shouldn't take? And what about me, the caregiver? What should I be doing? I just spent some time today talking with a caregiver who is overwhelmed by the cognitive impairment that someone they've loved for 50 years is facing. And of course, this becomes a threat to them as well. And as good physicians, we have to think about the diet, what's happening to both. So I think this is a very complicated set of illnesses that requires, I think, really superb management, not just diagnosis.
Yeah, it's hard to overstate just how practical and helpful the roadmap can be. Just thinking about another example, a friend of mine, her dad had Alzheimer's and he had been living in his house for several years. His wife had died and it was time to move him into assisted living. It just wasn't safe for him to be alone in the house anymore, even with care. And her loved one, the one with dementia, he went back and forth about the assisted living. Sometimes he would talk about, maybe I should move. She took him to a tour. He really loved it. When he was there, he really loved it. But then he would go back home and sort of nestle into the comfort of being back home and then would say, I'm definitely not going. I'm definitely not going. And it got to the point where my friend, she had actually, it had been a good day for him. He really wanted to go. He was excited about it. She had put down a deposit. The process was in motion. The wheels were turning. She had, she had taken time off work to come and facilitate this whole move. And halfway through the week, he reversed again. And he said, I'm not going. You're going to have to evict me. I'm not going. And this question came up, which is a very practical question, which is, do I cancel the deposit? Do I get more caregivers and try to make it work in the home and screech the brakes on this process? Or do I push forward and just kind of ignore what he's saying right now the way I would treat a toddler? What do I do? And she was asking advice from people in her life, and a lot of them said, well, maybe he just needs a couple months to get used to the idea. And then she actually called the facility, and the facility said to her, actually, in this particular type of dementia, more time doesn't really help. It's not like 2 months from now that it's a symptom of the dementia, and you just kind of have to rip off the Band-Aid and do that. And I just remember seeing her just really struggling, like, do I do I blow up this whole plan? How do I think about the balance between what he's saying and his autonomy, but what I know is best for him? And so it just makes me think about having a roadmap or having access to a dementia nurse or a dementia helpline or just dementia social workers, people who understand the disease and how it manifests to guide families through these, I mean, their logistical decisions, their financial decisions. Um, and there's so much that can be studied and learned about like how to respond in those situations.
And I think the thing that you touch on is often we institutionalize someone too late for their own good. And I often phrase it, I said this exactly to this person who I like very much. I said, it seems like the situation is close to unlivable for you and also for your loved one with Alzheimer's. And we're going to try some medications, some environmental changes in your house. We're going to work on the sleep and the anxiety that has emerged. But it's trial and error. We don't have certainty that any of the things that I'm going to try are going to work. And so at the same time, we have to think about whether maybe we need a new environment, an environment that is different. And I think that is something I say often, and it's very truthful and it's very honest. But I think it begins to prepare people for the idea that maybe being at home is not working. Sometimes it works better than institutionalized. Often in poorer families where there are a number of people living together, they do a better job than wealthier families who have all sorts of resources. They're used to it. They step up. But every situation is different. And without a doubt, one person cannot do this alone.
Yeah, it really is a disease process that impacts the entire family. And then I guess at scale, as our population ages and we start to see more of these diagnoses, how do you think about that at the level of society, populations? Like, how are we going to accommodate the, sometimes people call it the silver wave. I don't know if that's the right term or not, but I'm curious if you have any thoughts about how we might think about this situation from more of an epidemiological standpoint.
I think of it in a few different ways. One way I think about it is the importance of elders, even in our evolution as a species. So we have what have been called grandmother genes, and these are genes that protect the brain later in life. We're one of the few species, maybe the only species that has such genes. And what it says to me is that in these early societies with small numbers of humans living together, those that had grandmothers and grandfathers, I hope, did better than those without. And I think almost all of the people listening had elders who have had massive impact on their own lives. So this is a very important wave of people that we really want to protect. I think the good news is that in some ways we are protecting them by better health maintenance. I remember when my daughter went to her 7th birthday party, all of the girls got out a soccer ball and started playing. That didn't happen a decade before. Young women did not play sports. They didn't exercise like this. So I think there are many revolutionary things going on within our society that are meaning that as I get older, I'm less likely to have amyloid in the brain at 70. On the other hand, as you say, we are aging. We have more centenarians than we ever did. And I think the older we get, the more likely we are to suffer from dementia. So we have to be practical. We have to think about what a society can withstand in terms of interventions. We have to think about whether the interventions that we're doing are really making a difference or not. But I think the work is really important. And I think the more we can protect our elders, I think the safer the next generations will be. We elders still have something to say to the new generations. And the things that really seem to improve and at least maintain themselves are emotion regulation, happiness. Unbelievable, isn't it? But elders are actually happier than teenagers and people in midlife. So this is something to look forward to. And then I think there's something we haven't studied much, but it's wisdom. What are the importance of making your grandchild take skating lessons if they don't like it? Or, these questions that come up every day for families. And I think this is a place where grandparents really help. It's just babysitting, being there. These are all things that we really want in our elders.
I think that's a beautiful note to end on. Is there anything else you would like to share with the Remo audience, people listening who are caregivers or have a loved one with dementia or who are in this space and thinking about the future? Any final thoughts for the listeners?
First of all, gratitude to Emily Silverman, who is one of the world's greatest interviewers. Thank you for the chance to think with you together about dementia and aging. And, thanks to Remo Health for caring about this. We really are suffering an epidemic of degenerative diseases because we're getting older. And we need all of our systems engaged. We need primary care. We need consultants if we're going to keep up with this epidemic and make sure people do the best they can with these illnesses.
I have been speaking to the wonderful and brilliant Dr. Bruce Miller. Bruce, thank you so much for coming onto the Remo podcast.
Thank you, Emily. Thank you.
Thanks for listening to Talking Dementia with Remo Health. If you're looking for more information, resources, and expert insights, visit remo.health and subscribe so you never miss an episode. Until next time, take care.